Okay. And I just want to be respectful of everyone's time and would like to thank you for being here. We're very excited to do this webinar describing COVID-19 related disparities and vaccine hesitancy. And I would like to acknowledge that this webinar was put together as a collaborative effort from the Offices of Diversity and Inclusion at the Schools of Medicine at the University of Arizona, the University of New Mexico, the University of Colorado, the University of Utah, and the University of Nevada, Reno. There are planning committee members who are not on the panel, but who we would really like to acknowledge for their contributions to this panel. And they include Dr. Victoria Rain, Dr. Francisco Moreno, and Dr. Jose Rodriguez. One more housekeeping business that I would like to go over is that we will ask you to please type in your questions in the Q&A box rather than the chat feature, so we can keep track of those. And then for those of you at the University of Arizona College of Medicine, Tucson, please use this information to receive credit as diversity, equity, and inclusion hours. I would also like to acknowledge that we're covering a very broad and important topic, and that we cannot address all of the relevant information that we would like to address. So this will be, well, definitely not today, certainly not today, but we'll do our best to make sure that we're covering the most relevant information. And because we cannot cover all of it today, we're doing a two-part series. So part 2 will take place on March 9th at 1 p.m. Mountain Standard Time and 12 p.m. Pacific Standard Time. So today we will present you with relevant data and descriptions of the problem areas in specific groups that are represented in the Southwest regions that our schools of medicine are serving. And then in part 2, we will focus on some of what we're doing and some possible solutions to the problems that we're presenting today. So with that, I'd like to introduce you to our distinguished panelists, and then I'll hand it over to them to present you with the information that we're covering today. So first on our panel, we have Valerie Madera Garcia, who is a PhD candidate in epidemiology at the Mellon and Zuckerman College of Public Health at the University of Arizona. She earned a bachelor's degree in chemistry with a minor in biology from the Inter-American University of Puerto Rico in San Germán, Puerto Rico. Before coming to Arizona, Valerie completed her Master's of Public Health in Environmental Health from Ponce Health Sciences University in Ponce, Puerto Rico. Amidst the current pandemic with COVID-19, Valerie has worked in several efforts to improve Arizona's epidemiological response. During the summer, she worked as a spatial analyst for the Pima ACTS project, creating a COVID-19 dashboard for the Pima County Health Department. Valerie is part of the group of scientists working on the Test All Test Smart program for COVID-19 at the University of Arizona. Their goal is to ensure employees and students' safety by identifying asymptomatic people among the campus population. We're really excited to have Valerie present her data. And next on our panel, we have Francisco Lucio. And Dean Francisco Lucio serves as the inaugural Associate Dean of Equity, Diversity, and Inclusion at the University of Arizona College of Medicine in Phoenix. Dean Lucio is responsible for the continued cultivation of a diverse, inclusive, and equitable environment for all faculty, residents, fellows, students, postdocs, and staff. He has helped create a 5-year inclusive excellence strategic plan, establish a Women in Medicine and Science group, and bolster LGBTQ programming, amongst other initiatives. In part, these efforts have contributed to the College of Medicine Phoenix receiving the prestigious 2019 and 2020 Insight into Diversity Health Professions Higher Education Excellence in Diversity HEED Award. Dean Lucio is Assistant Professor of Practice in the Obstetrics and Gynecology Department and co-director of the Health Equity Longitudinal Curricular Theme. Dean Lucio obtained his Juris Doctorate from St. John's University School of Law, where he was the recipient of the American Bar Association, Health Law Section, and National Bureau of National Affairs. And he has an Award of Excellence in the Study of Health Law. Next on our panel, we're very excited to have Dr. Gail Dina Chacon, who's an enrolled member of the Navajo Nation. She's a professor in the Department of Family and Community Medicine at the University of New Mexico School of Medicine, where she founded the Center for Native American Health, CNAH. She served as Surgeon General for the Navajo Nation and was a member of the Advisory Council for the Office of Minority Health, U.S. Department of Health and Human Services. Currently, she's the Executive Director of the Native American Budget and Policy Institute, NABPI, in the University of New Mexico Center for Social Policy, which analyzes research and budget policies in areas of health, education, and environmental justice for our Native children, families, and communities. We're very excited to have Dr. Dina Chacon, Dean Francisco Lucio, Valerie Madera Garcia, and Dr. Amira Del Pino Jones is next on our panel. She's an associate professor in the Department of Medicine Division of Hospital Medicine at the University of Colorado. She's the Director of Diversity, Equity, and Inclusion for the Division of Hospital Medicine and the Assistant Program Director for Diversity and Inclusion in the Internal Medicine Residency Program. She's also one of the Assistant Deans of Student Affairs in the School of Medicine. As the director of several pipeline programs geared toward underrepresented undergraduate students interested in careers in the healthcare field, Dr. Del Pino Jones is dedicated to diversifying the healthcare workforce in an effort to improve the quality of care for all patient populations. Very much looking forward to hearing from Dr. Del Pino Jones. And last but not least, we have Dr. Ricardo Correa, who's an associate professor of medicine and program director for the endocrinology, diabetes, and metabolism of the University of Arizona College of Medicine, Phoenix, and the director for diversity and inclusion for graduate medical education. Dr. Correa completed his medical school and education master's at the University of Panama. He completed a research fellowship in epidemiology and tropical diseases at ICGES in Panama City and his internal medicine residency at Jackson Memorial Hospital, University of Miami program. In 2012, he was honored with the AOA and the Gold Doc Award from the University of Miami. He then pursued his clinical and research fellowship in endocrinology with special focus in neuroendocrinology and adrenals at the National Institutes of Health. Dr. Correa is board certified in medical quality. He's the author of the book titled Case Report, Basics and Publication, and senior co-editor of the book Endocrinology of Aging. His research is focused on neuroendocrinology, mainly on pituitary and adrenal tumor and healthcare disparities in diabetes in Latinx populations. So now we will go ahead and present you with epidemiological and other important factors associated with longstanding systemic health and social inequities that have to do with the increased risk of getting sick and dying from COVID-19 for many minority populations. So we will then also describe information that is specific to Indigenous and Native American communities, African American and refugee communities, and Latinx communities. So with that, I will hand it over to our first panelist, Ms. Valerie Madera Garcia.
Thank you, Dr. Domardero. Welcome, everyone. My name is Valerie, and I will be talking about the COVID-19 data. Up to February 11, there were about 27.1 million cases reported, which yields a rate of 7,951 cases per 100,000 people. And about 470,000 deaths has been reported in the United States. Next slide. The CDC published this infographic to explain the race and ethnicity disparities regarding COVID-19 cases, hospitalizations, and deaths. American Indian or Alaska Natives, Black or African Americans, and Hispanic or Latinos are more at risk for hospitalizations and deaths from COVID-19 than white non-Hispanic people. Next slide. Now I will be presenting COVID-19 data for 4 states. In the graphs, the gray bar represents the population distribution by race ethnicity based on the 2010 US Census. The blue bars are the COVID-19 cases and the black bars are the COVID-19 deaths. I will be comparing the percentage of COVID-19 cases and deaths to the percentage of the total state level population by race ethnicity to illustrate an indication of disparities. Here is the data from Arizona until February 10. The highest percentage of COVID-19 cases and deaths are among non-Hispanic whites, but these percentages are not higher than the percentage of non-Hispanic whites people within Arizona. The data also shows that the percentage of African American Indian or Alaska Native people who have died from COVID-19 is higher than the percentage of this group in the population of Arizona. Next slide. Colorado's data shows that there is a disproportionate burden of COVID-19 cases among Hispanic or Latino people, as the percentage of COVID-19 cases is higher than the state level percentage of this group in the population. Next slide. In Nevada's case, we observed that 35.2% of the cases of COVID-19 has been among Hispanic or Latinos, and that this surpasses the percentage of Hispanic or Latinos in this state. This data also illustrates that the percentage of Asian people who have died from COVID-19 is higher than the state level percentage of this group in the population. Next slide. Lastly, most cases and deaths occur among Hispanic or Latino people in New Mexico. The percentage of cases among Hispanic or Latinos is higher than the percentage of this group in New Mexico. Within American Indian and Alaska Native people, we can see a marked racial disparity as the reported number of cases and deaths are higher than their percentage in New Mexico's population. Here are the COVID-19 vaccination data provided by the CDC. Until February 11, 46 million total doses of the COVID-19 vaccines were administered, with around 34.7 million have received 34.7 million people have received the first dose, while only 11.1 million received both doses of the vaccines. Next slide. Here is the vaccination data for one or more doses administered by race ethnicity. The percentage of non-white people receiving the vaccine is low compared to the 62.9% of white people that received the vaccines. We can see that the vaccine has been disproportionately administered among minority groups, and race ethnicities disparities can be seen.
Thank you very much, Valerie. We're going to pivot now to the topic of systemic racism and vaccine hesitancy. Of course, covering these two topics as a backdrop to contextualize what we've been seeing since the onset of the pandemic and the inequitable burden of COVID-19 cases, deaths, and as was illustrated earlier, is something important for us to consider. Next slide. So that we have a common language when we talk about systemic or structural racism, we mean a system in which public policies, institutional practices, cultural representations, and other norms work in various, often reinforcing ways to perpetuate racial group inequity. That part is very important, that racial group inequity piece. It identifies dimensions of our history and culture that have allowed privileges associated with whiteness and disadvantages associated with color to endure and adapt over time. Structural racism is not something that a few people or institutions choose to practice. Instead, it has been a feature of the social, economic, and political systems in which we all exist. Next slide. Having a law background, it was most, I think, close to home to think about systemic racism in the lens of the criminal justice system. And so what we have here is an example where in the late 1970s, there was a policy by the US government to have a war on drugs. That war on drugs precipitated legal mechanisms that included some harsh sentencing, mandatory minimum sentences, and 3 strike laws in various states for those individuals who were arrested and charged with different kinds of drug possession charges. And then we couple that with enforcement that was vigorous enforcement that looked at something called broken windows policy, looking at low-level kinds of crimes, violations that were committed, but mostly in Black and brown communities. And so that added to over-policing of those communities. We had stop and frisk policies that were highlighted very much so in New York City, for example, that had an impact. And despite the fact that we saw Black and white Americans sell and use drugs at similar rates, Blacks were more than 2 times more likely to be arrested for a drug-related offense. So the confluence of the policy, the legal mechanisms, and the enforcement had some dramatic impacts. And those were very burdensome on the Black and Latino community. As you can see there on the right, what we ended up seeing is a prison population that overrepresented the population of individuals in society. 12% or 13% of the population, Black African American, 33% of that population is the prison population. Similarly, Hispanic population, Latino population at about 16 in society, but 23% of that population in prisons. And so this is an illustration of systemic racism having that impact on racial and ethnic minoritized populations. Next slide. As we think about systemic racism in health, medical anthropologists, Dr. Shepard-Hughes and Locke remind us that sickness is not just an isolated event, nor an unfortunate brush with nature. It is a form of communication, the language of the organs, through which nature, society, and culture speak simultaneously. The individual body should be seen as the most immediate, the proximate terrain where social truths and social contradictions are at play. We can go next slide. The American Heart Association recently published a look at systemic racism in cardiovascular health. In that publication, they depicted very nicely, I believe, what we see with the history, the laws, the policies, the mechanisms that impact people in their daily lives and adverse cardiovascular disease outcomes. The first, the top layered 3 rectangles that you see there very much tied to the history of slavery in this country for Black African American individuals that led to then, of course, emancipation, but continued oppression of folks through things like the Jim Crow laws that really created legal segregation for folks. Redlining that impacted who was able to receive money or loans to be able to purchase things like homes that targeted the Black African American community. This was coupled with a justice system that that included a lot of racial bias. And what we ended up seeing were the concentration of poverty and social determinants of health that negatively impacted the Black African American community, in particular in this example. There, that middle segment, you see poor access to healthcare, poor housing conditions and physical environment, poorly funded schools, poor access to capital. That those upstream factors, of course, have that downstream impact on health, which in this case, we're looking at increased cardiovascular disease and stroke, and also coupled with toxic everyday stress that individuals experience. Ultimately, we see poor cardiovascular disease and stroke outcomes for Black African Americans. Another illustration of systemic racism and health intertwining. Next slide. The personification really of these structures is the health disparities that we see. The CDC put out this infographic here that looked at high blood pressure, diabetes, stroke, compared to African Americans compared to whites. And we see disparities starting at earlier ages for the two different groups. In particular, of course, African Americans seeing the burden of the disease at a much higher rate than whites. Next slide. And as we consider those social factors that have an impact on downstream health outcomes, we see differences as well with the Black African American community as compared to the white community in different categories like unemployment, those living in poverty, a lack of home ownership that we know is an entryway to generational wealth for people in this country, and inability to see a medical doctor, smoking, inactivity, and obesity that we know are really impacted by environmental factors, such as not having safe spaces to go outside and exercise, as well as food deserts, and the high cost of food, healthy food for individuals. Next slide. What we know to be true is that there is a specter of medical abuse that has been practiced in the history of our country. We have examples of James Marion Sims, who is known as the father of gynecology, who experimented on Black slave women to perfect procedures. And we see an image there of folks where the former statue in Central Park stood of James Marion Sims. When we think about some of the medical abuse that we've seen in Native communities, we have examples of coerced sterilization as a form of birth control for Native women, something that was being practiced in the 1960s and 70s. And in that image there on the lower left, you see what is taken as a brochure for planning family purposes for Native folks. But what we know is that this type of family planning was not often explained very well to patients, not often explained in the language of Native individuals, and folks weren't told that sterilization was not reversible. And we have a long-standing history of sterilization laws that were really founded in eugenics laws that we saw in places like California that disproportionately forcibly sterilized women of color in the early 1900s through the 1970s. Next slide. And of course, we have examples that many know about in terms of medical abuse with the Tuskegee study, and also Henrietta Lacks and her cells being taken and used without her consent. Next slide. But we also have some more contemporary examples of incidences where the trust with the medical community was called into question and shaken, in particular with Black and Brown communities. In the 1990s in New York City, there was a fenfluramine study that that looked at an attempt to link violence and biology. The children in this study were all Black or Latino, recruited from Washington Heights. And the study design was very flawed in that way because it was all Black and Latino children. In addition, those children were selected because they had siblings who were a part of the criminal justice system, and there raised some ethical concerns about recruitment practices where families might think that perhaps if they didn't participate in a study, their family members may be treated poorly or receive harsher sentences. In this case, there were no sanctions and violations found, but there was an outcry from the community once this became public. And again, shaking the confidence of science and medicine. We also had an example in the late 1980s, early 1990s, when the CDC had funded a study of a measles vaccine in children in Los Angeles. They gave an experimental measles vaccine to children who were mostly Black and Latino. And this happened to about 1,500 children. The measles vaccine was something that was being used in other parts of the world, but was deemed experimental here in the United States. And this was something that parents did not get full information on. And so that informed consent was something that was a challenge. And then finally, we have some accounts of women in particular who had given reports of unwanted hysterectomies and unnecessary medical procedures in ICE detention centers that happened in 2020. Next slide. And so this backdrop, of course, is important as we're thinking about vaccination and the desire for folks in these hard-hit communities to be vaccinated for their protection and the protection of the public. But what we're seeing here in some early studies is that vaccine hesitancy is something that's alive and well in the Black and Latino community. We see here in this study, 34% of Blacks and 29% of Latinos or Latinx were definitely not going to vaccinate or were likely not to get vaccinated, compared to only 22% whites and 11% Asians. Next slide. And so we know that there are a multitude of variables that are at play with the decision for folks to want to get the vaccine or not. This study that was published in November with the NAACP COVID Collaborative, Unidos Us, and the Langer Research Associates surveyed over 1,000 individuals, and they found that the trust in the vaccine safety was something that was low amongst Black survey participants at 14%, compared to 34% for Latinx Americans. Trust in the vaccine effectiveness was low at 18% for Black Americans as compared to 40% for Latinx Americans, and trust in culturally specific testing and safety also low. 28% for Black Americans and 47% for Latinx Americans. Some of the narrative responses I think were important. On the left there, you can see folks saying too much haste in developing this vaccine. Politics is being put before people's health and safety. Another survey responder said, I am not confident that this really is a prevention for COVID-19. I feel like it could be have other sinister or ulterior motives for African Americans. And finally, one responder said, I'm afraid it may cause me to have the virus. Next slide. Thank you.
Yeah, Twitch eating inchla, Kia Ani Bashichin, Hachitni Dashache Ado Kentlachitni Dashanala. Good afternoon, everyone, and thank you for the other panelists, my colleagues, and everyone there who is allowing me to be a participant and present today. So thank you. This is an honor. Next slide. I will speak about the indigenous populations, and I am originally from Navajo Nation, from Chinle, Arizona. So you heard Francisco Lucio talk about systemic racism and social determinants of health as key concerns for COVID in populations, and certainly on Navajo Nation that is has been a big impact. We have social factors that impact the overall health of our people, and these are basically what I see as failed policies enacted and forced upon our sovereign nations. Unemployment on the reservation is pre-COVID, not unheard of to be around 50%. COVID currently probably around 60 to 70% of unemployment on our reservations. Over 50% of our adults have not received a high school diploma. Our living conditions, I'm not sure about poor housing, but it's certainly not enough housing where you have a lot of multi-generational families living in homes, which may be inadequate because they may not have enough running water, where 33% of our houses are without running water, and 78% of our roads are not paved. Certainly lack of broadband, which is a huge problem, not only on our native lands, but in many rural communities across the nation, which has broad impact on a lot of what we do every day. A lack of access to care. Indian Health Service is a provider of our health care for eligible American Indian Alaska Natives, and for decades it has been severely underfunded, and certainly so today with this pandemic. And we all know about our underlying health conditions that predisposes to death due to COVID, such as obesity, diabetes, and heart disease. Next slide. This is a CHR, or perhaps in southern Arizona and southern New Mexico, a promotora. But this is our community health representatives making a visit to a family out in the Navajo Nation. Again, the dirt roads and the housing, and it looks like propane is probably the way to go for cooking and possibly heating besides fire. Next slide. This is a family trying to access broadband at Fish Point, Arizona, which is, I say, down the road from Chinle. Way in the background is where my grandma, her house is way up where that mountain is. But this is a family trying to access broadband for their child to do schooling. And this is one of the only ways that they can get that. Next slide. New Mexico, we have New Mexico report cards on race and ethnicity, and this just shows the trends in diabetes for American Indians, and that top dotted line, the blue line, is American Indians. You can see it kind of goes up a little bit in 2015 to 2017, along with the African American population as well. But those are the high percentages of diabetes in our native groups. Next slide. The also just looking at influenza and pneumonia, and the reason I pull this up is because there's high rates of infectious disease that today that still cause death in our American Indian populations. One of the outbreaks of SARS, we had a high rate of death due to SARS as well from respiratory illnesses. So influenza, pneumonia, and of course now we will have COVID that will, deaths due to COVID will bring that, you know, we'll see in 2020 and 2021 how that green line is going to go up and rapidly go up, unfortunately. Next slide. So this is the underfunding of Indian Health Service. This is where American Indians, for it's always a sensitive issue when we talk about our land and loss of our land, and yet, you know, promises of healthcare and education for our people. And yet that promise has been not well kept. As you can see, the beneficiaries of federal funding for healthcare, a Medicare participant or someone receiving per capita payments for Medicare is $13,000 per individual per year. A veteran may be receiving $10,600. Medicaid beneficiary is $8,000, and an Indian Health Service in exchange for our lands that were stolen This is how much we get per individual for our health care is $4,000 per beneficiary. Next slide. This is the Navajo Nation overall beginning back in March. And we have an epidemiology center, the Navajo Nation Epidemiology Center, which tracks this data every day. And they do the 7-day average. They've been looking at this. You can see the ups and downs, and it's interactive. You can go to the website and see every day how this changes. That it also shows the lockdowns because we are a sovereign nation. Our tribes and tribal leaders have that obligation, that public health obligation to protect our people and our lands. We have weekend lockdowns. You can see the green area with the weekend lockdowns. Those were really at night, Friday night, Saturday night, Sunday night, and then complete 57-hour lockdowns began with that orange section, and those were instituted Friday night to Sunday morning, where everyone was in lockdown. You could not leave or possibly even leave your home. And then now it's gone back up again. And the interactive website will show you and explain these areas. So I encourage you, if you want more information, to go to the website. Next slide. Oh, I'm sorry, really quickly about that. Can we go back real quick? I'm sorry. Back in September, the Navajo Nation and Mississippi Choctaw individuals had the highest death rates, 2 to 3 times more than New York City per 100,000. So we heard a lot about New York City having, the ground zero or the, epicenter. But really, if you really looked at it, the epicenter for COVID deaths in the nation was Choctaw Nation and Navajo Nation. Next slide. So this just shows a little bit different graph from the originals that were in the beginning. For overall throughout the United States, the deaths per 100,000 people, and this just goes down the list of how it's listed on top. So Indigenous deaths are right up there as being the highest per 100,000 people. Next are Asian, it shows a lower, and then of course the next highest is Black, and then the next highest is Pacific Islander, and then Latinx is right in there with that lighter, or that blue color. Sorry. Next slide. This is adjusted for age. This is important because when we adjust for the ages in our minority and ethnic groups, you can see that these numbers actually look different. So here, Pacific Islanders have the highest rates of mortality due to their age populations, because minority populations tend to have higher birth rates and higher numbers of young adults and children. Then if you adjust for that, we have a high rate, the highest rates of COVID mortality in Pacific Islanders, then Latino, Indigenous, and then Black. Of course, the white populations, their age adjusted is still about the same. They have a high rate, they have a high number of an elderly group in their populations with lower numbers of the young. Next slide. And this just shows the last 2 slides, New Mexico and Arizona, which look very similar. And this is the death rates in New Mexico. Shows that the Indigenous population, and it is just very evident that it's the highest number and still going up of COVID related deaths in New Mexico. The 2 dark lines there are hard to discern between the 2, but that is white and Latino, and then the bottom is Asian. Next slide. And then this is again in Arizona. That shows the same similar graph, and that shows the Indigenous population again with the highest death rates in Arizona per 100,000. And then the 2 dark lines are are Hispanic and white, and then the one underneath is African American. So I think that's it. Thank you.
Great, thanks so much. So I will be talking a little bit about the impact of COVID on our African American and refugee communities, specifically in Colorado. Next slide. So as the coronavirus pandemic has evolved, headlines like these have been very common. As outlined by many of the speakers, racial and ethnic minorities often make up a smaller proportion of populations, but account for many more of the coronavirus cases relative to their populations. So this includes African Americans in Colorado. For example, I am a hospitalist, and it was very easy to see that there were disparities in terms of hospitalizations. African Americans make up 4.6% of the population in Colorado, but accounted for 11% of the hospitalizations. And as of January 2021, 2% of individuals who have received the vaccine in Colorado identified as African American, and this is compared to 73% who identified as white. So while this may speak to the continued mistrust for the healthcare system, it's important that we take a deeper dive into why vaccine hesitancy and disparities exist. Next slide. Dr. Terry Richardson, a physician and vice chair at the Colorado Black Health Collaborative, said that while systemic disparities play a part in the impact of coronavirus on Black residents, more specific data is needed to determine exactly what is going on in Colorado and how to counteract it. Specifically, she said, I know most people are saying it's related to the disinvestment in Black communities, longstanding health disparities, a lot of social determinants, or it's because African Americans are doing front-facing jobs, bus driving, working at restaurants. These are the types of things you hear. But for me, or for Dr. Richardson, she said, I think we have to really try to take a deeper dive into this data. Really, what is happening? So specifically, she said the state needs to provide specific data on Black patients who are dying from COVID-19 that examines the patient's risk factors like age, chronic diseases, or occupations. So again, things beyond race. And ask questions like, did they present to the hospital? When did they present to the hospital? How long were they hospitalized, etc. Next slide. And an April 2020 survey of over 1,000 Coloradans conducted in partnership with Healthier Colorado and Magellan Strategies highlights some of the ways Blacks and African American Coloradans have been hit hard by the virus. So specifically, 30% of Black and African American Coloradans were struggling to pay for the basic necessities of life before the coronavirus outbreak. And it's only gotten worse, with 42% now reporting difficulty paying for food, housing, utilities, and healthcare. Additionally, Black and African American Coloradans are worried about the health impacts of the coronavirus and want the government to do more to protect the public's health. Next slide. Now, this is a picture of the Mango House. So according to an article by the Colorado Sun, when the Mango House is in full swing, and this is pre-COVID, there are a handful of clothing stores, international grocery stores, restaurants, tailoring shops, jewelry stores, and there's a place even where refugees can go and get help on their taxes. There's a mosque that's open on Fridays and a big ballroom available for refugees to host fundraisers and other events. As you can see here, the ceiling of the food hall is adorned with flags from around the world, and the walls are covered in pictures of smiling faces. Next slide. As you can see, the Mango House was hit hard by the COVID pandemic, and most shops have actually closed. There's a clinic there, a clinic specifically for refugees that is run by Dr. Parmar, and this has remained open. For Dr. Parmar, there are a handful of factors that contribute to the high percentage of positive coronavirus cases he's observing within Aurora's refugee populations. And this is more than double the 21% seen overall in the state. Now, for this specific clinic, they do not take appointments. They're open on the evenings and the weekends to allow for better accessibility for patients. And 90% of the patients are on Medicaid, meaning that their copay is only $2. As you can imagine, a lot of our community clinics are unable to accommodate the number of Medicaid patients for various reasons, usually having to do a bit to the reimbursement. But Dr. Parmar has made it so that this is his clinic is accessible to many refugees. Next slide. So as far as coronavirus risk factors associated with refugees, some that have been listed include people living in close quarters with family and friends, and specifically in Colorado, this is thought to be related to the high cost of living in the Denver metro area. Other things that we need to consider is the reliance on public transportation for a number of these patients, or a number of the individuals in this population, as well as many of them are considered essential workers as well. Once again, other things that we should be thinking about and considering include fear of seeking care due to their refugee status, sometimes the information on their green cards not matching up with what we have in the system, fear of poor communication during hospitalizations due to language barriers and lack of interpreters, and other fears amongst refugee populations. Next slide.
Thank you. Good afternoon. And now we are going to talk about the Latinx community. Next slide. So just a brief background, 60 million of Americans representing 18.3% of the entire US populations are Latinx descendant. 63% of them are Mexican Americans. And we have to think about this as a community that is mainly young population with a median age of 29.5 years old. They are low income. They, as Dr. Dennis Chacon mentioned, they also are crowded households as Native Americans, and they are mixed families where there are multiple generations living in one house. They have a limited, sometimes education and sometimes English proficiency when we talk a little bit more about the older population. And as I mentioned, there are large families. The healthcare is also a problem for the Latinx communities. There are a lot of underinsured population. They have limited visit doctors. Sometimes they don't understand what is because of the poor health literacy, what is their disease that are happening. So this is something that as a community we need to overcome. And occupation, they're the frontliners. So these are the janitors, and the majority of them works in construction, in grocery stores. So these are the people that have been in the front line during this pandemic and in the front line in all the jobs. So in the next slide, I want to take two examples of two big states in the South and the West. So California, in California, 39% of the population, or 15.5 million people, are Latinx. And we know that almost more than half of the cases in California of COVID-19 has been because I've been in Latinx communities, and 46% of the death, almost 1 out of 2, die from COVID-19 are Latinx. In Texas, the 12 million out of 29 millions are Hispanic, and we can see that almost 1/3 of the cases are from Latinx community. So when we look at zip codes and social determinant of health, as all my prior speakers mentioned, this is also a community that is very affected, and affected in all multiple ways. So next slide. I just bring here some data from California, from Arizona, sorry. So if you can see from the total cases that was reported by the Arizona State Department up to February 5th, 29% of the cases are coming from Hispanic or Latinos. As you can see from the underrepresented minorities in Arizona, they are the ones that are more hospitalized compared with others, and also the ones that have more death. Almost 1 out of 3 deaths in Arizona is from Latinos. Next slide. So using this model of the Swiss, the Swiss cheese model, we can also have a model of how to improve and success and things that we are going to do. So if we divide this into what are the personal responsibilities and shared responsibilities, we can see that there are multiple interventions that we can use with the Latino community to improve. from the education part, where they understand that this is a personal responsibilities and physical distancing. And I don't like to mention social distancing, because in the Latino community, social distancing have a different tone. So it's physical distance, the way that you should express it, hand hygiene, and also trying to use mask and all these barriers. Also, there is a shared responsibility where the community and the government should play important. And at the end, as you see, to be very successful is the vaccines and how to address vaccine hesitancy in this community, so we can achieve our goal. Next slide. So what are some of the barriers that we have faced working in some underserved clinic, mainly seeing undocumented Latino population? So basically, is one of the things that we have seen is lack of access to the testing. So it depends on different states, but here we have seen that at the beginning of the pandemic, it was very difficult to have some access to resources for testing this kind of community, or they were asking things like your ID, where we deal with a lot of undocumented people. So that's something that was a barrier in that. The other thing is the healthcare, the health insurance are not the best for this community, and also the majority of this of the population that we see have no health insurance. So this is a burden on them. The next thing was the public share rule for trying to, the ones that want to get some permanent status, which there was a hold at the beginning, then there was not hold with the past administration. So that was affecting a lot the issue about public health and COVID, and then the testing and all that. So there's also a barrier in language. There is not a lot of healthcare providers that speak the language, that understand the language, and then that at the end, what happened is translate to less attention and less seek for healthcare with this community. And as Francisco mentioned, there is already a stigma for prior things that has happened in the US through history against this community too. In the next slide. So what are some of the outreach intervention that has worked? And the most important is gain the trust of the community with confidentiality and trying to provide the best services to them. Having a bilingual, not just a translator, but a bilingual healthcare provider that understands the culture is very important. This culture is based on family, is based on community healthcare workers, promotores, de salud. So those things are really important in the community. So that's things that we need to promote and then to teach them so they can teach their community. So also we need to be aware on what are the resources that community that we are talking about have, and if the main problem has been the food insecurity or in undocumented immigration problems, that kind of things we need to be aware. Next slide. So as a healthcare workers, we play a critical role on all of this. We need to, one, encourage our patients to get tested and get isolated, understand why they need to be isolated meanwhile they get their results. And isolation is not so frequent or so easy to say, oh, just get a room when you have a 4 bedrooms house and then you can isolate it in one room. This community, we're talking about that in one room, 10 people leave and multi-generations leave. So we have to be careful in how we transmit our message and to understand the situation of that specific person and family. Educate what will happen if the tests come positive, and what are the implications if the test come positive, and when is the need to go to the hospital, and what are the safest hospital around the area where they can go, where they will not have any repercussion about that. Very important to see if there is community resources. Our clinics serve as a community resource for them. So that's something, if you can find a community clinic that is doing this, they can do it. And then become a reliable source for everything related to the COVID-19 and the vaccine. And tell the patient very important in Latino community is when they trust somebody, they will follow that instruction. So tell the patient, if you get already the vaccine, that you are vaccinated and the vaccine is safe. So that constant education in not just the daily day with the patient, but also in the radio, in the news, in Spanish speaking social medias, all of that will help that community to grow and trust and then have the vaccine. Next slide. And finally, some key recommendation is for the Latino community, family-oriented messages are the best. So the best way to protect yourself and your family is to get vaccinated. So it's very important to mention that this is not only to protect you, but to protect your family. That is a very impact message to the Latino community. Also, clarify any myths and misconceptions that they can have. A lot of the issues that comes to Latino communities because abuelita was telling me something, and then they trust a lot in the family people. And they have to understand that this is a new disease and a new vaccine. So nobody have experience with this in the past. So the best way to trust is the healthcare providers. Vaccine protects healthy individuals and high-risk individuals. Very important to address this because it's a vulnerable population. These are people that are going in the front line and they are more prone to have suffered some of the disease. So we have to tell them that this will protect them. And finally, as I mentioned in the past, trust is vital. So tell them if you were vaccinated, that you were vaccinated. If you have any adverse reaction, as in 80% of the people have adverse reaction, what they have to expect, that will clear the communication. And at the end, the population, the Latinx population will trust you more. And with this, thank you so much.
Okay, I would really like to thank our panelists for the really important information that they've provided us, and also for the really important, crucial work that you're doing to help address these health disparities. And I want to let our attendees know that we are going to be speaking more in terms of what all of our schools of medicine are currently doing in order to help address and close the health disparities gap. I also wanted to let you know that we are happy to answer any questions, and please go ahead and type them into the chat function, and we'll go ahead and ask our panelists to answer those questions for the next half an hour or so. And again, we are going to be doing a part 2. My connection is not stable right now, but we're going to be doing a part 2 of this seminar on March 9th at the same time as this seminar, and we really hope that you're able to join us. We want to make this more interactive so that you can access our panelists to ask any questions that you may have, and we'll also be presenting you with information, as I said, in terms of what our schools are doing and what we can do as providers to help address the issues that we're presenting you today. I also wanted to highlight that if you want to get CME credits, you can text the code that's on the slide, so 336016, to that number, and we'll also ask you to please use this QR code to complete the grant rounds evaluation. Yes, there will be a sign up for the second part of the presentation. We'll advertise it just like we did this one. Let's go ahead, and I'll go ahead and start asking the panelists to answer some of the questions. Again, thank you for a wonderful presentation. This information that you've provided with us is just invaluable, and I really appreciate it. I'm also reading comments from the audience saying thank you for this vital information. So first question that I'll ask, and maybe Dr. Correa can answer this one. The question is, as a healthcare worker, what one thing can I do that will help the most in terms of gaining the trust of minority populations who are not trusting the vaccine?
Yeah, thank you so much, and a great question. I will answer from the Latinx perspective, and probably Dr. Dina Chacon and Dr. Pino Jones can answer from the other perspective. One of the most important things in addressing vaccine hesitancy in the Latino population is addressing it on the correct language, so in Spanish, and acculturated by that population that you are seeing. Hispanic population is not the same. They're coming from different parts. So when you are addressing Mexican and Central Americans, it's different as addressing South Americans, and it's different as addressing the Caribbeans. So you have to understand many times is what is their misconception, where are they coming from? Many of them are using some herbal, they are trusting some of the things that are seen from their family that are in their home country. I have seen multiple of them, for example, thinking that the vaccine is not working, so that's why they're using ivermectin or hydroxychloroquine, because that is what they are using in their home country. So understanding that background and addressing that will increase improve the literacy in the vaccine that we have, and then definitely, if you teach by your example, because you wear mask, they are going to wear mask. If you get the vaccine and then you tell them what's your reaction, how are you feeling, what is to expect about the vaccine, they are going to trust you. In the Latino community, the physician is an important part as the priest. So they really trust that community people. So I would recommend just understanding a little bit of what the community that you're addressing, and then addressing them in their cultural and language.
Thank you, Dr. Correa. And I'd like to invite any of our other panelists to answer the same question if you have anything that you'd like to add to what Dr. Correa just mentioned.
I think I can say a couple of things for indigenous populations and specifically Navajo Nation, where I'm from. I think actually speaking with our, again, division or Department of Health for Navajo Nation, they feel that the response to getting vaccines has actually been fairly well received. There hasn't been a lot of pushback, and I think you might what I see and what I hear from, my family members and my community, it's mostly those who are following the wave of why, in some of those, concerns of why this has gone out, this vaccine has occurred, so has been created so fast, and things is this a political, is there some politics behind this? So there's always that group that you're going to encounter. Actually, Navajo Nation was one of the tribes that early on had clinical trials for the Pfizer vaccine. So there was a large population, or a large group of Navajo people who were in the early clinical trials for Pfizer. So that, not that there wasn't any controversy around that either, but I think that it certainly helped with exposing and having people discuss and talk about having a vaccine coming to the Navajo Nation fairly quickly. It didn't mean that we got it sooner than anybody else, but it certainly had the conversations and discussions happening. And certainly what Dr. Correa said about, the language, making sure that there's culture, language, all of these things that are appropriate. Our Navajo Nation president has been right up front to be that model for talking to the people. And I think that for our populations, especially our Indigenous, our Latinx, our African American populations, our elders are so important. They carry, one elder passes, that's a library of our history, of our language, of our culture. So being able to pass that to the people and talk to them that this is our most precious resource, not only our children, but our elders who carry on the language, who carry on the culture and the traditions and the family traditions. So that's, you have to kind of just go back and look at the big picture and say what's so important to us, and bring it home to our families.
Thank you very much, Dr. Dinachakon. That is really useful information that we would not have access to otherwise. And Dr. Correa, and I'd like to open it up to other panelists if there are any additional ideas for specific populations. Please feel free to answer this question.
Yeah, I was going to say there's definitely a lot of varying opinions on this, but one thing that I have found that has worked quite well, I'd say in general, is just acknowledgement of things that have happened in the past, validation for people's feelings because of what has happened in the past. Just being, as transparent as possible about what the current processes are and what the benefits are of the vaccination. But I think, for a very long time, as healthcare practitioners, we haven't wanted to talk too much about the things that have happened in the past. And I think that just creates even more mistrust for a lot of our patient populations. So just feeling comfortable having those conversations and again, listening to your patients and what their biggest concerns are, and then trying to address that with the data that we do have now. And as I said, the benefits of the vaccine.
Very, very true, very important. Thank you, Dr. Delfina Jones. Any other thoughts that any panelists would like to add to this question of addressing vaccine hesitancy?
Yeah, I would say that, as a non-MD, but it's sort of thinking about, maybe getting into what we might cover in the next presentation. But as hospitals, as educational institutions, as part of other institutions, it's important, I think, that we put out messages for community members that depict those healthcare providers who look like those communities that we're trying to reach. As Dr. Correa mentioned, speaking in the language that's native to those populations, to engender that trust and to hopefully improve some of the vaccine information-seeking behavior. We know that there are some studies that looked at that already, and when there's some concordance between the community and the health providers, that increases some steps in the right direction for patients around vaccine hesitancy. So these kinds of either educational campaigns or being out in the community and talking with your local faith-based organization or other group, working in tandem with them to help reach those folks, I think will be helpful and important, because I know that folks are perhaps experiencing challenges with the vaccine availability and getting appointments and some logistical challenges, but this process will be long, and this issue will be something that remains for us to continue to try to address. So I think from that organizational perspective, those kinds of things will be important.
Thank you, Dean Lucio. And we will be talking more about this during our next webinar, part 2. So please feel free to ask those questions if you have further questions. That will be the main focus of our next webinar. So the next question that we have here, I'll start with Dr. Dinachakon. It's about whether the new administration has indicated that they have any plans to increase IHS funding.
Well, how IHS funding occurs is so we're in the fiscal year of 2021. So this budget formulation that happens probably about 2 years ago, probably back in probably 2019 or 18 to formulate the current budget. So we're always a couple years behind from when the budget actually gets approved by Congress and then gets through to actually how much will be appropriated. This past year, I think the budget for IHS for 2021 was about 6.5 billion. And that was just I think about 400 million of that was an increase from the previous fiscal year. But currently with this administration, I believe there was Indian Health Service has been provided specific funding. I think they received $1 billion just at the beginning of this month, specifically for COVID. So that would be for testing, contact tracing, and vaccinations, and a lot of things associated with COVID. So, the money comes, through congressional appropriations, and we certainly have the organizations to help advocate for that, such as National Indian Health Board, which is a big advocacy group for the tribes.
Thank you very much, Dr. Dina Chacon. The next question that I would like to ask is for Dean Lucio, and it looks like you addressed this in the chat already. But just if you would like to talk a little bit about the representation of minority groups in the vaccine trials.
Sure, yeah, I did provide a link from the Kaiser Family Foundation that looked at the racial ethnic distribution of folks who participated in both the Moderna and the Pfizer trials. One of the things to note, though, is that we actually did get some relatively good participation of different racial ethnic groups, in particular Hispanic or Latinx folks for both Pfizer and also Moderna. They were higher represented in terms of the number of folks who are in the population by percentage, and those who participated in the vaccine trials. Where we had the slightly lower representation was amongst the Black community. What we had was about 12% of those folks who are represented in the population of the folks in the United States who are 16 and older, and 9.8% of those who participated in the Pfizer trial were Black, and 9.7% were those who participated in the Moderna. So although slightly lower, we actually did have pretty good representation from those groups. And happy to ask some of my MD colleagues to comment as well.
I just want to echo Dean Lucio for one of the things that was important is that we can see that underrepresented minority, not as we want, but they were active participating in the vaccine trials. And that was because a lot of education coming from the healthcare providers telling the importance of being participating and being represented in these trials. This is not the end. We will have a lot of more medication coming, a lot of more things to come, so that we need to continue having that participation of the underrepresented minorities. So when we have to prescribe something and give something, we have the data for that community. And if Dr. Moreno is here, I think that he can expand a little bit more on all of this and all of our research.
You guys hear me okay?
Yes, we
Yes.
can hear you.
I hope you guys can hear me. Yeah, and thank you, Dr. Correa, for the invitation to comment. I think in terms of the vaccination, I think Dean Lucio is exactly correct that there was a concerted effort that took place actually later into the process of vaccination testing to really emphasize the importance of bringing in members of the underrepresented communities who do have special social needs that make them a unique group that may require special attention during the testing. The good news is that we did have a total aggregate of the underrepresented minority groups in our country that were represented adequately after those interventions took place. But it is exactly those interventions that we need to continue to have now so that people get the vaccines. Particularly, I wanted to say that our rates of vaccination of minorities have been very low. As we started rolling down from people over 75 and now over 65, members of the underrepresented communities, particularly African American communities, American Indian, Alaska Native, and Hispanic groups, are less facile with the use of technology. And so enrolling through the internet, waiting for an appointment, trying to set something up, ensuring transportation is something that can be really overwhelming. And so we all need to be working closely to have promotores and family members that can really help facilitate that process in order to improve the rates of vaccination.
Thank you very much, Dr. Moreno. The next, it's not really a question, it's a comment, but I'm wondering if some of our panelists would like to comment on this one. It says, as providers of color are asked to do more outreach, to use their language skills to model precautions, let's hope that academic health centers reward and pay for such additional skills and work. So if any of our panelists would like to comment on this, please feel free. And please type in any more questions that you may have in the chat box.
You know, I can start, and I think this, for me, this comment highlights that there is such a great need for us to continue to diversify our healthcare workforce. We know that the numbers are not where they need to be in terms of representation of underrepresented groups in medicine. You know, when we have challenges like this on a global scale, where, you know, we might be struggling to find somebody who is a physician who speaks Spanish and can reach out to the community, or speaks another language, or you know, has the native cultural background to be able to engender that trust. You know, this is where, you know, we really see the deficits of that lack of diversity in our academic health centers. And so a reason why the efforts to continue to diversify are so important, because when we have low numbers of individuals who have those particular skill sets or profiles and backgrounds, we do lean on them. We ask them to do more. There is certainly that minority tax that we talk a lot about in academic medicine that plays out for folks, and you know, something that we certainly, you know, need to keep striving to correct. So that's I think a very important comment, and one that highlights this fundamental need to continue to reflect the communities that we're serving, so that we can overcome these kinds of medical challenges when they arise.
So this is actually Josh Lee, not one of the formal panelists for today, but part of the University of Arizona and Banner Health. And as being part of the health system side, that deliberateness in recruitment really suffuses almost all of our efforts. And even though I think when we look back on what's been our penetration of underrepresented communities in our general workforce, we seem to look pretty good, but when you then begin to look at ranks of manager and director and above, the percentages fall off. So one of the key strategic initiatives, what's called the long-term initiative within Banner Health, is actually to change that ratio in leadership positions, because that tends to then, if colleagues see people of their own community in leadership positions, it then not only instills them wanting to stay in that particular workforce, but it provides a source of comfort for communities who say, should I trust this health system? Because when they look at who are the leaders, that makes a huge difference. So I want to say there is deliberateness specifically in leadership and in advancement towards having, as Dean Lucio said, leaders that represent the communities we serve.
Can I just say very quickly, thank you, Dr. Lee, for that comment. You know, this has been, that's probably the biggest, one of the biggest things that I see where I'm at in an academic institution is, first of all, you know, really being at the forefront of being out in the community. Those are precious and delicate relationships to be building in our communities. We put ourselves on the line to be able to do that, and it's usually one way, but really has to be honored that this is a two-way relationship, first of all. So those relationships and partnerships are very precious and need to be strong. The other is having those leaders in those roles that reflect your population. And if we have a large number of Native students, and I'm using Native because that's where I'm from and that's what I know, is that we have a large percentage of Native students in our medical school or in our health sciences center, there's also that need for recruiting and retaining Native faculty at all levels, and at those leadership roles, whether they're chairs. There are, if you look at AAMC and the percentage of American Indian as chairs or deans or higher, it's like less than 1%. And it's these numbers are very low. So how can we, you know, be expected to continue this outreach without having that favorable acknowledgement and being able to rise to those levels that should be just automatic and expected.
Thank you. I'm just so grateful for all of our panelists and attendees for the just really great questions and thoughts regarding what we can do. There was an additional link here provided by Dr. Jacobs. And Dr. Jacobs, would you like to comment on this?
Sure. Hello. Hopefully you can hear me. So I'm aware that the National Medical Association has put out a beautiful love letter to Black Americans, and it's really about encouraging and building that trust and addressing some of the historical and current medical racism and structural racism that we see in medicine. And it looks like Dr. Correa put a similar link out of the National Hispanic Medical Association. So these can be great resources, but we will be focusing on solutions and how to increase diversity of the healthcare workforce and how to better train culturally humble providers in our next part on March 9th. So hopefully you can join us for that.
Thank you, Dr. Jacobs. And with that, I'm not seeing any additional questions. So if any of our panelists have any last comments or issues or thoughts in terms of any of the questions or today's presentation, please feel free to go ahead and speak now. We have about 5 minutes left.
I would just like to sort of sharpen the focus and say that, you know, although we did talk about the backdrop of systemic racism and historical accounts of medical abuse, you know, the challenge isn't just that. The challenge is the everyday experiences that individuals have when they interact with the medical institutions, when they interact with individual, physicians, and when we make the efforts to interrupt the bias, to make the efforts to curtail any microaggressions against especially minoritized populations. I think this has to be part of the solution. And so it's not simply recognizing that these medical abuses have happened and that they are part of the history, but that every day people can help to engender trust by the way that they in particular treat folks from minoritized populations. And that's, I think, empowering for people that you can help build that trust, that's that connective tissue that's so important right now for these efforts around getting folks vaccinated for the betterment of their health and everybody else's. So I just wanted to make sure to point that out.
Thank you very much, Dean Lucio. That was a wonderful closing remark for today. And I hope people can join us for part 2 of this seminar. It sounded like there was a lot of interest in learning more about what we're doing and what we can continue to do in order to address these very serious problems that we've highlighted today. Once again, thank you to our panelists and to the planning committee who put in all the work in terms of helping prepare this seminar for all of us to learn from each other. Thank you to our audience for all of your great questions and insightful comments. And thank you to the CME committee and to all of the people who worked behind the scenes to make this happen. There's a lot of work that went into preparing this for everyone. So I just want to say that I really appreciate every single effort from this wonderful team. And we very much look forward to seeing you for part 2 of our seminar on March 9th. Have a wonderful rest of your day, everyone.